Good day, friends, and a warm welcome to episode 9 of season 2 of 4D, that is, detailed discussion and dialogue in Indian diabetes. We are together in this journey, like we always say, and our journey is towards better health, better glucose control, and we want to become the diabetes care capital of the world. But if there is one city that can claim to be the diabetes care capital of India, that perhaps is Chennai. And a warm welcome today to our special guest, Dr. Manoj Kumar Shah, who works at the Madras Medical Mission, the prestigious Madras Medical Mission at Chennai in Tamil Nadu. Warm welcome, Dr. Manoj.
Thank you, sir.
Dr. Manoj has an illustrious career not only as a clinician but also as an educator. His main focus is diabetes education, and he has pursued multiple postgraduate courses in health science, in diabetology, and patient education specifically. And apart from that, he is certified in endocrinology. And it's not that he's a clinician and educator alone. He also works in clinical trials. So he's a researcher. And you will find that he has played an active part in research for diabetes, diabetic foot ulcer, heart failure, obesity and cardiovascular outcomes, and also lipidology and chronic kidney disease. His papers, his presentations add value, add luster to his career. But the main focus, Dr. Manoj, of your career, as we see from your CV, is cardiovascular disease and diabetes. Is that correct?
Yes, sir. So, because I work in a center which is more renowned across because of the cardiovascular disease, and we are pioneers, one of the pioneers in terms of cardiac procedures. Actually, in fact, our hospital was inaugurated by Dr. Bernard himself, the renowned cardiologist. So,
Okay. So that is nice. A rich legacy, a very rich legacy that you are taking forward. Uh, Before we begin your talk, which is on cardiovascular disease and diabetes prevalence in India, how busy do you remain managing diabetes and managing cardiovascular disease, or do you feel that both the questions are actually one? Can you differentiate in your OPD between CV disease and diabetes?
yeah, actually, I feel both are one of the same. It comes from the same soil, and you we see patients coming with cardiovascular disease and get diagnosed of diabetes, and we have patients a known case of diabetes for, let's say, 5 years or 10 years, and then they're landing up into cardiovascular disease also. So yes, it is one the same, and we all know that diabetes is already cardiovascular equivalent disease, and the basic soil, fertile soil, what is the known for about diabetes and cardiovascular disease becomes your obesity and our lifestyle, which has been changed over the period of years together. So yes, I feel, and it keeps us busy because it is a tertiary care center, and as all tertiary care center, it is more of an inpatient where we deal with, and we have multiple procedures throughout the day, and we have CAPG done, we have PTCAs, angios, and then they have patients who are admitted for heart failures. More of the care is towards towards the inpatient, and I feel that when you're taking care in the inpatient part, you have got ample of time to educate the patient in terms of to prevent further progression of the disease itself, and also to prevent other complications which can happen to the patient over the period of time.
You're right, and that focus on education, which you are sharing with us, that is actually the basic philosophy of 4D. When we get together as one India, as one country, to work for better health. What Dr. Manoj tells us reminds us of the banyan tree. So, metabolic syndrome, CV disease, obesity, diabetes, it is actually like a banyan tree. And it is written, the tree of life in the Bhagavad Gita. The roots are upwards, the branches go downwards. So, actually, it's difficult to differentiate what is the root and what is the branch when you're looking at cardiovascular disease and diabetes and all the other associated diseases. But Dr. Manoj, the banyan tree also provides shade and shelter
Yes.
to weary people. So, would you like to share information, knowledge, wisdom with us regarding this concept?
Definitely, sir. Yeah, like as you said, really said, the banyan tree provides shade, shelters to us. Similarly, when a patient gets diabetes, what I feel is like if you educate the patient, it is always we look into prevention. So once the patient gets diabetes or hypertension or dyslipidemia, you work towards prevention of complications. And also at one same point of time, I also tell my patients that okay, you get diabetes at the age of, let's say, 50, there are good chances that your offspring will get diabetes at the age of 40 itself, and even earlier to that. And same thing goes with the complication. It happens 10 years to 15 years prior in the earlier in the offsprings. So if you get diabetes, you are going to lead a healthy lifestyle so that you prevent the complication at one aspect. And also seeing that your children will also learn how to tackle with this lifestyle management, and they can prevent the onset of diabetes and all little complications. Once the patient gets into, let's say a patient has undergone CABG, then again there is a scope of education there itself, where the knowledge of uncontrolled sugars or their whatever they have suffered with. So with that, they can at least work towards prevention of other complications and also improve the quality of life. Ultimately, I think what we all work towards now, we have moved away from let's say glucocentric approach. Now we have gone to uh, organ protection, like your diabetes, also along metabolic disease, along with your cardiovascular protection and renal protection. And all of this we are doing is just to improve the quality of life of the patient. So I think we all we need to improve the quality of life of the patient by proper and the baseline. What happens is, like, has as the banyan tree, it provides shelter to the huge large surface area, like compared to other trees also. Similarly, if it is like a ripple effect, if I educate one patient, and if that patient is able to educate two different patients, because you see, like, people are going into multiple groups when they're walking or when they're doing a physical activities and all. So that group, when if they are able to do the ripple effect of educating about diabetes to their co-friends or their partners, I think it will go a long way in terms of spreading the health awareness and also towards prevention of all the complications.
Thank you so much, Dr. Manoj, and we look forward to listening to you now on your regarding CV disease, diabetes, and their prevalence in India.
Sure. So I'll just uh, share my slides.
Yeah.
So I hope my slides are visible and am I audible.
Perfect, perfect.
Yes, sir. Good evening to one and all, and I would like to thank Dr. Sanjay sir for this wonderful introduction and this wonderful opportunity to connect with you all on this wonderful occasion of uh, talk, the forum what we have started with, the 4D. So I will be talking about prevalence of CVD and diabetes in India. Okay. And as I already said, that both CVD and diabetes comes from a single soil. So now let's look into the prevalence of diabetes. And if you look into this study, where a global burden of disease which is projected in 2015, it was estimated that around 422 million people are prevalent of CVD. Out of that, South Asians will become the largest contributor. And if you look into the Indian per se itself, it is CAD is prevalence in around 21.4 percentage in diabetic, and also in non-diabetic by around 11 percentage. Why it is very important? Because it is also said that in India itself, the total death because of CVD is around 26.6 percentage, and daily, that is disability adjusted life years in India, is around 13.6 percentage. And if you look compared with your rural versus urban, the rural part of country is nearly half than the urban population in terms of prevalence of cardiovascular disease. And if you look into the per se of cardiovascular disease, what happens is, like, the major chunk is basically because of acute coronary syndromes and ST elevation, that is MI. Then comes your hypertensive heart disease, and then also you have got rheumatic heart disease, which forms around 1.5 to 2 per thousand individual. So yes, it is important. And if you look into this again about CVD epidemic, whether it's a matter of concern, yes. From if you look from 2000, from 1990 to 2016, it is said that there's a 2.3-fold increase in prevalence of both ischemic heart disease and also stroke. Okay. And if you look into the prevalence of CVD, there's a 2.5-fold increase in number of CVD from 2.7 million in 2000 in 1990 to 54.5 million in 2016. Now, why this becomes very important? Because along with with the prevalence of disease, you have got this economic loss. And according to this report of World Economic Forum and Harvard School of Public Health in 2014, it's already estimated that from 2012 to 2013, you will have economic loss of around 2.17 trillions. And I'm sure this number is already exceeded beyond that. A good data from Kerala also suggests that the the health expenditure associated with MI, that's acute myocardial infarction, remains to be high in those without health insurance. And if you look into my hospital, the basic charge of your CABG itself will be around 5 to 6 lakhs. Stenting will cost anyways more than 2 lakhs. Okay, so yes, it is a costly disease, and if you are able to take a proper steps to prevention, it will always be handy for the patient. Now, what are the risk factors why the patient develops cardiovascular disease? And it is smoking, diabetes, hypertension, dyslipidemia, obesity. I think obesity comes into all the aspect. You have got genetic risk factors, and age is one factor which nothing can be done. You have got environmental factors, which is your lifestyle, where we are looking into. Especially we see with most of the people who are usually young age and they are working in IT fields, or people who are in working as a night shifts. Okay, and then the treatment gaps where we are not able to really tackle this diabetes, hypertension, dyslipidemia at the early stage itself. You have a risk factor of developing a cardiovascular disease. Now let's look into the prevalence of diabetes in India as per se, and you see the map of India is beautiful with colors. The top one is about diabetes, and second one you see is the lower one, which is about pre-diabetes. And yeah, and then you have a smaller graph which is about India as per se, urban population and rural population. So if you look into this prevalence of diabetes, you see that around it is more filled with red marks in the urban population. Whereas if you see into rural population, especially Kerala, West Bengal, and if you look into Punjab and Himachal Pradesh, you have got the prevalence goes more than 10%. Otherwise, it is okay. So you see the urban population has got a higher number of prevalence of diabetes. But if you look into pre-diabetes, you see that it is almost similar, whether it is urban or rural population. The prevalence of pre-diabetes is almost similar. Okay. So, if you look into the individual in 2019, it was around 77 million people are living with diabetes, and it's projected by 2030 you'll be having 100 million people with diabetes, and by 45, which is approximately 15 years from now, it'll be around 134 million people living with diabetes. Okay, and there are the major factor is like there are around 43 million people who are undiagnosed of diabetes. So there's something called pre-diabetes, there's something called undiagnosed diabetes, and there's something called diabetes. Okay. So that is one part. And if you look, the average A1C among them will be around 8.3 percentage. The national prevalence of diabetes is around 8.9 percentage. The important factor is like diabetes related death is around 1 million in 2019 itself. So it is a staggering number. And if something is not done at the initial stage itself, these numbers are going to explode in a higher way. Now, burden of diabetes, if you look across, especially in India, also you see that. Now, let's see whether it's world, Southeast Asia, and India. You see that the incidence of diabetes around 10.5% is across the world, 8.8 in South Asia, but in India itself is around 9.6%. And by 2020, by 2045, you see that the rise will be 12.5 percentage, 11.5 percentage. India will be around touching to around 11 percentage. Okay, what is more important is the disease burden or the daily, which is daily adjusted life years, in 2016 was around four folds for diabetes, and it will be the leading cause in terms of uh, daily in India. Okay. And if you look into the non-communicable disease, you see that from 1990 to 2016, there's a steep increase in terms of non-communicable disease. Okay, and from 35 position we have already reached to 13th position. So what are the risk factors of diabetes? Again, is almost similar to what we had earlier for CVD. There's a risk factor for diabetes is your family history, your BMI. If you are towards overweight or obese side, you become a risk factor. And more than BMI, I feel that even the waist circumference, if it's on the higher side, you have got a risk factor for diabetes. In a healthy, inactive lifestyle, if you have got any comorbid condition like hypertension or dyslipidemia, if there's history of gestational diabetes, if you're age more than 40, or if you already have got impaired glucose tolerance or impaired fasting glucose. So there are a few risk factors which you should be taking care of. Okay. So what are the strategies where you can, because both comes from a similar soil. So the the strategies will be almost, if you can tackle, if you are able to uh, use these strategies, you'll be able to prevent not only diabetes but also cardiovascular disease. So one is about promoting health education and awareness about the pathophysiology about diabetes and CAD. So also tell that you need to give a ripple effect in terms of diabetes health educations and awareness. Okay, you have to discourage your social habits like smoking and tobacco use. It's always a saying that okay, you are jumping, if a flight is going to crash and you jump from the flight without a parachute, anyways you're going to die. So if you are able to prevent diabetes and hypertension despite you are continuing with smoking and taking tobacco, again the the end factor is death only. So that definitely you have to encourage the patient about this social habit, and always tell the patient that they need to eat a healthy diet and exercise routine should promote so that they can have a better cardiovascular disease, and not only blood sugar control but also it will help in their blood pressure and dyslipidemia also. Okay, and the quality of life will definitely improve if they have got a healthy diet and exercise. In diet, what you should do, you need to decrease your high fat content. The carbohydrate and saturated fat has to be reduced, and there should be increase in terms of fruits and vegetables. Okay, there should be aggressive screening. I earlier used to say that after age of 40 you should start getting a master health checkup done, but I feel now as the age duration, as the onset of all the cardiovascular disease are happening at a younger age itself, probably I think you should start screening them at the age of 30 or at least 35. Okay, and always promote healthy group exercise activities such as yoga, walking, meditations should be practiced regularly. Okay, so therapeutic strategies again is very important because you have got newer medications. Now there's a concept of moving from glucocentric approach towards your metabolic and cardiovascular and renal protection. Okay, where you have got good medications like after the advent of your empire trials, we started getting uh, indications where you can use these molecules not only for sugars but also for their cardiac protection and renal protection also. So you have got when it comes to DPO inhibitors, you have got sita, saxalina, and allogliptin here, which is cardiovascular safe. Okay, then you have got in SGLT2, you have got canagliflozin, dapagliflozin, and empagliflozin, and yes, you have got GLP-1 receptor agonist, which will improve in terms of in future you will have more amount of data with GLP-1 receptor agonist. What does they all these medications do? Is when you initiate with the combination therapy, they are helpful in terms of beta cell preservation. Okay, and we have seen with the data when you combine DAPA with sitagliflozin, it is well tolerated and in patients who are inadequately controlled of diabetes. And the combination therapy has helped to achieve the patient's A1C targets faster than the monotherapy. Now, there are few benefits in terms of this combination therapy, as they have got a complementary effect, and we all know about the omnis octet. And you see that I feel when you combine uh, dapagliflozin or when combined your metformin, SGLT2 inhibitors, and DPP inhibitors, we are able to cover most of the pathophysiological aspect of diabetes. So, what does SGLT2 inhibitors do? It will increase your glucosuria, it will increase your beta cell sensitivity, and also increase your glucagon. In terms your DP4 inhibitors, it will have an incretin effect where there's an increase in your GLP and GIP, there's increase in the insulin secretion and decrease in the glucagon level. As a result, you have got decrease in your blood sugar, so hyperglycemia will come down. In addition, that the DP4 inhibitor has got a weight neutrality benefit, but with SGLT2 inhibitors, there will be decrease in your weight, there will be decrease in your systolic blood pressure, there will be decrease in your waist circumference, there will be improvement in your LDL, HDL cholesterol. The LDL may slightly go up, but there's improvement in your HDL cholesterol, and also there's a decrease in your uric acid level. So overall, if you see this SGLT2 inhibitors, it will tackle your metabolic uh, pathway, your metabolic syndrome in a very good way. Okay. So there's always recommendation of initiation of combination therapy with SGLT2 inhibitors and DPP inhibitors in type 2 diabetes patients with CV risk with or without heart failure. Okay. So because with the data which is prevalent with your SGLT inhibitors, which has got a CV proven CV benefits, and it does wonderful job when it come in terms of heart failure. DPP inhibitors, again, it has got a CV proven benefit, and you have got reduction in terms of hospitalization of heart failure. Okay, so it is a suitable combination therapy in patients with severe risk factors, even including patients with heart failure. So with this, I would like to conclude, and back to you, sir.
Thank you, Dr. Manoj. A very great talk, really crisp. I'm reminded of this saying, prescription has a paracrine effect. That means it will just affect the person sitting next to you. But education, like you said, it has a ripple effect. Education has an endocrine effect. So whatever education you have shared with us right now, that actually has an endocrine effect, because it will help so many people across the country, doctors, and through them their patients as well. One question coming from the audience is, uh, now that we have FDCs, for example, we have dapagliflozin, sitagliptin, has that made life easier for you in terms of counseling your patients?
Yeah, definitely, sir. Actually, if you look into my patient, where I see in a tertiary care center, the patient will have multiple medications with them, and they will have some 8 to 10 medications. The first thing what the patient says is like, "Can we reduce the medications?" And we all know that it is a quantum of disease where the reduction of medication may not be possible. So when there is a combination therapy, the pill burden comes down, and the mental satisfaction is there with the patient when there's a decrease in pill burden. So I feel that fixed dose combination works good, especially in our patient. But I initially don't start with the combination therapy. I will give it in a separate dose, a separate pill. And once the patient is stable, there's no complaints in terms of genital urinary infection or infection or any other complaints. If they don't have, then I would like to combine them together. So I tell the patient, okay, I will combine them. I'll give you a lesser medication. This is the first time I'm seeing you. So let me give the prescription may be long, but on the next follow up, I'll be able to decrease it down.
That is a very good practice, actually. So you make a finite request. Finite means like for the next 1 week or 2 weeks, please take 3 tablets or 4 tablets, and promise that 2 weeks down the line, we will reduce the number of drugs.
And I
Specific.
ask one question to the patient, like, have you walked today, or are you doing physical activity? I don't ask about I don't see the report. The first question with the patient is like, are you doing any physical activity? Because I know most of the patients will be doing the diet properly, or they say that okay, I am following proper diet, but when it comes to physical activity, most of them they don't do. So that's how I start. And once you start asking this question again and again, next time the patient comes, definitely the patient will say, yes, doctor, I am doing some physical activity. I have started these changes in my lifestyle, and they see the result. And the good thing is, like, suppose a patient has started the physical activity, and because of this combination therapy, the patient have lost weight. I don't tell that you have lost weight because of drug. I said it's because of your activity you have lost weight, and this motivates them to even go further. So
So
there's an
two.
enhancement in the efficacy of the drug for weight loss.
Yes. So two very good practices coming from Dr. Manoj. One is that you keep on very subtly just nudging the patient towards physical activity. You are asking a question, did you exercise today? But it's not just history taking, it is also a therapy. So it is a theranostic tool, therapeutic and diagnostic. Diagnosis because you diagnosed whether the patient was doing physical activity or not, but therapeutic because that actually works like therapeutic patient education. And then the second good practice that Dr. Shah is sharing with us is saying thank you to the patient. So if you put the onus of control on the patient, the ownership on the patient will respond. Patient will actually take charge of himself or herself. So thank you, madam, for having taken care of your husband. You are cooking such tasty food and healthy food in the kitchen. Thank you, sir, for exercising. Thank you for motivating your wife to exercise. We know that you have to walk slowly because you are working with her, and still you are so patient, you are so perseverant. So thank you, sir. So when you say thank you to the entire family, the best thing is, Dr. Manoj, they come back and say thank you to you the next visit. Even if the glucose is maybe 250 or 350, they won't be grumpy or they won't argue.
Yeah, true, sir. Actually, like I say that these numbers are not that important. The only numbers which is more important at the early stage of diabetes is your weight and your physical even if you're not able to lose weight, just do a physical activity properly, just follow a diet properly, these numbers will definitely come down. If you're I'm not I'll tell them I didn't like maths in my entire life, that's why I took biology, and I'm really not good with numbers. So don't worry with the number part. Just do your basics. If you keep your basic right, I think that every building's foundation is your the basement and the pillars. Here, the basement becomes your diet, and the pillars becomes your activity. And if you're able to do these two things properly, the building will be strong. It may take some time to construct that, but definitely it'll be strong. And I always give them that, okay, you need to along with your health, you need to take the health care of your children also. You don't want your children also to suffer from the same thing. So if you do a physical activity, your childhood, you brush, you go to bathe before going out of your house, your children does the same thing. So if you do physical activity, they also will see the and they will do the same thing. And that's how we are able to prevent these complications or this disease in the further generation.
That is another very good learning that you are sharing with us, sir, because you are telling us to use the opportunity in the OPD to prevent diabetes, and not only prevent diabetes in the current generation, but in the future generation, in the future of our country. One specific question coming from a listener. He is from the state of Haryana, and he says, "Sir, for a patient who is discharged after hospitalization for heart failure, can we prescribe sitagliptin dapagliflozin combination safely?"
Yeah, if the patient is stable, I think yes, your TCOS trial had shown that it was neutral in terms of heart failure, and the guideline says that the only drug which you can prescribe in the heart failure, if the patient is stable, is your linagliptin and sitagliptin. So yes, if the patient is stable without volume overload symptoms, you can prescribe the combination therapy, because anyways you're going to get a good glycemic control. Along with that, you have got dapagliflozin where it can take care of the extra volume overload which you have.
Thank you. There is one last question, and this is regarding chronic kidney disease. So the question is, sir, how frequently do you see patients with uh, coronary artery disease plus minus heart failure, along with maybe CKD stage 3? And in such patients, can we prescribe dapagliflozin and sitagliptin safely?
Yeah, if yes, sir, that's a very very interesting question, and I think I'll be happy to answer that. And we see most of the time when the patient has got heart failure, especially, and because of the diuretic use, and we all know that it is a cardiorenal syndrome, in fact, and with every failing heart, you have a failing kidney too. And this dapagliflozin becomes a good choice here, where it protects your heart also. And we have got good data from right from credence to dapa CKD and to empa kidney also, where all these drugs have shown that there is a decline in the progression of renal failure. And yes, obviously all the studies have shown that the heart failure component also is taken care. So yes, you can give. Only thing is like, and the recent guidelines have said that you if you are using SGLT2 in terms of CKD protection or heart failure, you can use up to GFR of 20. So you need not really worry of falling GFR when you're using DAPA. But yes, if there's a decline in the GFR, you have to be careful with the sitagliptin dose. So that we all know that for mild you can use to 100 milligrams. When it comes to moderate, it should go to 50, and then when it comes to severe, you can use up to 25 milligrams. So that dose common uh, uh, the component has to be taken care. But yes, it becomes a very good combination.
And Dr. Manoj, we'd like to thank you. Thanks from everyone who has been listening today. Your talk actually has been like a banyan tree. Not only the prevalence of CV disease and diabetes in India, you've also touched upon the pharmacological therapy, how we can use newer FDCs like DAPA-CETA in patients with heart disease and kidney disease. And the most important of all, the tips and tricks that you have shared about uh, developing a person-friendly, patient-friendly, community-friendly practice. I think that is most important of all.
Thank you, sir. Thank you. Thank you very much, sir. And I
Thank
think
you,
it's like
everyone.
the sun, where it gives your light, and we have a banyan tree here. So the sun gives lightning enlightenment for us. So simply, this forum is definitely useful in terms of educating not only to physicians but also like helping them to take care of the patients well. Thank you very much,
We
sir,
all,
for
yes,
being a
we all
part of.
learn with each together, and it is teamwork which gets us through. So, on behalf of Dr. Manoj and myself, I would like to thank everyone who has logged into this episode of 4D, and our season will continue with more episodes. With this, I'd like to thank everyone once again. Let's work towards a happier and healthier India. Jai Hind.